Thank you very much, Dr. Balaji, and good morning to each and every one of you. And I'd like to extend my personal gratitude to the Asia Fungal Working Group for having us here in this very important symposium. So I am tasked to open our last day of our conference and by giving a talk on the trends in antimicrobial resistance in Asia. So antimicrobial resistance, or AMR, is the development of resistance of the most common pathogens, which include, of course, bacteria, viruses, and even parasites, to antimicrobial agents, antibacterials, antifungals, antivirals, antiparasitic agents. And we all know that this is nowadays a very big public threat. So it's very important that we do understand the trend or the behavior of the resistance pattern of these enemies that we are facing right now. And I think that is the reason why this topic was also included in this conference. When I tried to collate data for my talk today, you do understand that the bulk of my presentation will be mostly on antibacterial resistance, but was able to get also some data on antifungal resistance, primarily on Candida species, which I will also present for today. So I don't have any disclosures. And because I'm limited to 20 minutes, so what I did was look into the most comprehensive AMR trend over time. And I was able to get from the Sentry data, and later on from the WHO GLASS AMR trend. And because currently we don't have uniform or a unified AMR trend from 2017 and beyond, what I did was look into your individual AMR trend in your own country. So I'll present some of them too. And zeroing in on Southeast Asian countries, and I included India and China. And of course, the Sentry fungal susceptibility patterns. And I was able to get the data from India. And they have a very good comprehensive data on Candida species AMR. So in this part of the world, in the latest WHO report, about 2/3 of the world population is in Asia. And they said that unfortunately, the 10 least developed countries also in our region, and this makes us very vulnerable to AMR. And they also postulated by the year 2030, about 27 of the 43 megacities will also be in our region. And this will further, was predicted to be the gap in antimicrobial resistance, wherein this very densely populated countries can be the reservoirs for drug-resistant pathogens. And specifically, among all the WHO region, it's the WHO Southeast Asian region that they identified to have very high infection rates, and hence are also the highest risk of having AMR. So with that, it's very important that we develop a surveillance system in our region so that we can see the trend and likewise be able to compare our data with that of the other continents. So it was said that AMR burden is very large in the Southeast Asia. However, even if individually we do have our own surveillance of antimicrobial resistance in each of our countries, there is a lack of a formal unified surveillance system over time that will address the AMR. And this creates a big gap, for we don't have the data that we can also collaborate with the rest of the world so that we can see where we're at, and also that we can see and measure if our interventions of AMS or the antimicrobial stewardship is also successful. So with that, with a lack of this standardized and comprehensive data, we unfortunately don't have a reliable AMR burden and the measurement of the impact of the interventions of our AMS. So then that again tells us that the surveillance of AMR is very important, especially in our region. So these are the examples of the networks contributing to the surveillance of AMR in Southeast Asia. However, there is one program that I was able to see, and this is the Sentry program. This is the largest and the longest running AMS or antimicrobial resistance surveillance initiative. It ran from 1997 to 2016, and there were about more than 1 million clinical isolates for more than 400 medical centers who collated their data, and they were able to generate quality and analyze data, and they were able to do this by also comparing antimicrobial resistance from the different continents. So here are the Asia-Pacific countries that were included in the Sentry data. Initially, the China and India were included. However, they were only able to submit clinical isolates during the first 2 years. So the Sentry data decided not to include their submission, the data coming from these two countries. So as you can see, most of the countries were from Europe and also, of course, from North America. So that's one disadvantage also of the Sentry program. But however, it is worthwhile to see the trends because they were able to generate important informations that later on were published, so many publications, hundreds of publications from the Sentry data alone, and also they were able to look at they were able to discover the emergence of new strains and even new species that was utilized by our microbiologists and also by clinicians as we render patient care in our own setting. So looking at the trend and zeroing on the Asia Pacific, again, what's good thing about the Sentry data is they're able to compare it with the other continents. But zeroing in on Asia Pacific, zeroing in on Asia Pacific, you will see that the susceptibility pattern to penicillin G was significantly lower. No, it decreases through time until 2008, when I think our region was able to see the problem and perhaps initiated some AMS initiatives, and then one good thing is that from 2008 until 2016, the susceptibility to penicillin increases. However, it's still very low at about 55%. So the next pathogen that looking at the MDR. So the definition of MDR is resistance to at least one agent, to at least three or more classes of antibiotics. So here, zeroing in just because we do know that this is one of our problems, the penicillin G resistant. It is not only to Pen G that was the problem of the Asia Pacific, but also resistance to macrolides and even cotrimoxads also. You will see here that the MDR Streptococcus pneumoniae were increasing until 2008, and however, significantly decreased again until 2016. So MRSA trend. So this time, what the Sentry data collated are from the nosocomial and the community acquired infections, and they looked into the bloodstream infections primarily. And here you will notice that our MRSA rates are, as we have expected, is higher for nosocomial infections. And the trend you will see is initially increasing, then plateauing, and then decreasing until 2016. Also similar behavior for the community-acquired MRSA from bloodstream infections. And when they when they looked at all the data that they have, the Asia-Pacific region has the second highest MRSA rate, second to North America here, so at 40.3%. Now, this is an Enterobacterialis, and I think you will agree with me when I say that among all of us clinicians, this is one of the problems that we are having in our hospital, increasing ESBL rates, increasing carbapenem resistance of our E. coli and Klebsiella. So the trend for the Asia Pacific is that we have the pink bars here. For ESBL, we're second to Latin America, our ESBL rates. And so this is the increase from the initial collection of data to 2016. So overall, there is a significant increase from 1997 to 2016. But you will see that in the Asia Pacific, our most problematic pathogens are the ESBLs, and the main driver is the ESBL producing E. coli. And for the carbapenem resistance, it's also here, the Klebsiella, the primary driver of carbapenem resistance Enterobacterialis is the Klebsiella pneumoniae. The MDR, we will see that we also have high MDR E. coli and Klebsiella pneumoniae at 11.7 and 8.5% increase from 1997 to 2016. So in this span of about 20 years, we have significant increase in AMR for Enterobacterialis. Now, zeroing in on carbapenem, because as I've said, this is one of our major problems nowadays. And the line graph here is the blue one, the light blue one. It is around 2008 that we started a creeping increase in carbapenem resistance that unfortunately, the trend of CRE in this part of the world is still increasing until 2016, as high as about 8%. But looking at Latin America and Europe, they really have very big problems on carbapenem-resistant Enterobacterialis or CRE. Now, let's now tackle Pseudomonas. And what I did here was look into the latest WHO priority pathogens. And MDR Pseudomonas, carbapenem-resistant Pseudomonas, Acinetobacter, Enterobacterialis are included in their priority or critical pathogens. No? So zeroing in again on Asia Pacific, you will see that this is the trend of MDR Pseudomonas. From a very low 16% in 1997, it increases to about 22% on 2009. And one good thing is the trend of MDR Pseudomonas seems to have decreased until 2016. And looking at, it seems to be that all throughout those years, it's the Latin America, again, which had problems with MDR Pseudomonas. And susceptibility through the years, we see that compared to Enterobacterialis, it seems to be that the MDR Pseudomonas, we are performing well in curtailing the MDR Pseudomonas, and hopefully this will continue as I present to you the next couple of data that I was able to gather. If you will look at the resistance pattern of Pseudomonas, what I wanted to point out here is that I think it's in the year 2005-2008 that there was a decreasing trend of susceptibility amongst all antimicrobial agents. And however, look at the use. Perhaps we are heavy users of ceftazidime and piperacillin tazobactam. These two are the antibiotics with the least susceptibility against Pseudomonas, based on the Sentry data. Now, this is the problematic pathogen that we have. And once you have this in your hospital, most likely an infectious disease practitioner will be called. So the MDR Acinetobacter baumannii, look, you cannot even imagine that in years in the past, it's just around 9%. No? And look at where we are now. It's as high as about 72% from 2013 to 2016. And this is true among all the continents. No? So perhaps the North American people, our colleagues there, were doing something that we have to learn when it comes to AMS. And this one is just to show you the susceptibility of A. baumannii against meropenem. Initially, it was the drug of choice for A. baumannii, but you will notice that the susceptibility through the years, and for Asia Pacific, it's just around 21% only. So what do we have? So this just tells us that how important AMS is in our own clinical setting. Now, looking at the possible antimicrobial agents that we can use overall, because it's a dismal performance. Now, all susceptibility of A. baumannii isolates, they all decrease through the years amongst all the antimicrobials, and we are left with at least 2 minocycline and colistin when you look at the overall susceptibility pattern of A. baumannii in our region. Now, I was trying to look after 2016, what other data do we have on the trend over time? So one good thing is that the WHO in 2015 created the World Health Organization global AMR surveillance and use system, or what we call GLASS. So this was a systematic collection of data globally, and it encompasses bacteria and also fungi, and they don't only zero in on resistance, but also on consumption. And these are the Asian countries that I looked at all the contributors, and by 2018, about 9 of the 11 Southeast Asian countries were included already or contributed data to the WHO GLASS AMR. Unfortunately, they don't, unlike Century program, they don't have specific data for Asia Pacific alone. So it's very difficult to correlate or establish a continuity of data using the Century and then the WHO GLASS. And that is, again, to emphasize the reason why in our continent we have to establish our own surveillance system. Now, if you're going to look at this, the median, this is the upper quartile and the median quartile. So if you're going to look at all continents, the penicillin G resistance seems to have stabilized. So it's just, it plateaued from 2017 to 2020. And we do hope that in Asia Pacific, we do hope that that is also the case. But as I've said, unfortunately, unlike in Century that we have the Asia Pacific data at 44%. However, if you will look into the GLASS data, even if you're going to look at the highest extreme of the upper quartile, you will notice that it's still much lower than the 44%. So it seems to be that based on the GLASS AMR, the resistance of strep pneumonia to penicillin seems to have improved. Next is the MRSA. So the median of MRSA based on GLASS is around at least almost 20, when the APAC is about 40% from the Century. However, look at the extreme data or the upper quartile, it reaches around 40%. So if we're going to correlate them together, we can show that this can show that there is nothing much improvement when it comes to MRSA rates. And then the next one, also for ESBL, Klebsiella, the time series for cefotaxime resistance of Kleb seems to be higher for all continents, but unfortunately we cannot say if this is secondary to drug resistance from Latin America perhaps, so difficult to conclude any data here. And meropenem resistance Acinetobacter baumannii seems to, the Asia Pacific from Century data seems to be the same as that of the GLASS, WHO GLASS AMR. Okay, So because we don't have much time, so I'm going to look at the AMR surveillance in Asia. So these are the data. Unfortunately, if I wasn't able to get from your country, you're very much welcome to give us the data of your country. Okay, so here, looking at the trend of MRSA in China, India, Thailand, Singapore, Malaysia, Philippines, and Japan, it seems to have plateaued. Everybody had plateaued except for, oh, it's us, Philippines, seems to have decreased a little. And look at the MRSA trend of India. I was so surprised that all their isolates are really MRSA. Yeah. So at ceftazidime-resistant E. coli seems to have plateaued too through the years. No increase, no significant increase or decrease. But what I would like to emphasize is that there are variabilities in our national data that we have. And it seems to be some are really performing well, like Japan, and some are really like China and India. Seems to have, we have to work on the AMS with them. Ceftazidime-resistant Klebsiella pneumoniae and meropenem-resistant Klebsiella pneumoniae. And look at Japan again. Can't believe it, 0. So they don't have some. No? Until 2019, their data showed that they don't have much of the meropenem-resistant Klebsiella. Trend of carbapenem-resistant Pseudomonas in Asia, and of Acinetobacter. Acinetobacter, this one, seems to have an upward trend for all, no? For all, and also, wow, look again at Japan. Okay, so now if there's one lesson that I learned from attending our symposium in the last 2 days, it's that the antifungal resistance data is there is a paucity of antifungal resistance data. And it is under-recognized as an important part of AMR surveillance. Hence, if you will notice, if I said that there were millions of isolates that were studied from about 400 countries for the fungal susceptibility, specifically Candida susceptibility in Asia Pacific from Sentry data, they only have 222 isolates. And it came from about 16 or 17 countries. So with the few isolates that they had, these were their report. And it seems to be that the resistance, the year and then the resistance, the percent resistance, seems to be with the glabrata. And the highest was on 2013 and 2014 at 28.6 and 16.7. Of course, Crucii, they did not test it for azoles already, so they just look at the echinocandins, and luckily there's no reported resistance with Caspo. And in addition to the glabrata, there were also some reported with parapsilosis in 2015. At 12.5%. But again, we have to be cautious in interpreting this data because of the very few number of isolates. One good thing is that the WHO established the glass fungi. So, however, this is just a protocol for helping out countries to establish their antifungal resistance surveillance or also those with existing antifungal surveillance to help them develop more and other initiatives, no, for AMS. So with the AMS glass fungi, unfortunately, there's no data yet when it comes to the Candida species. I really looked over and researched if they have published their data, but I guess it's because this was only in 2019. So I guess it's really the COVID. I think that's the main problem, because with the bacterial pathogens, they reported that there were very few countries who were able to submit data. So I think that is also the case here when it comes to the WHO glass fungi. So I looked and looked, and luckily I was able to get the data from India. And we really have a very comprehensive data on Candida species. And look at the numbers. They have very high number of isolates at 281, No, 168. So this is just to show you the number of isolates that they were able to collate through the years. And looking at the trend, it seems to be they don't have any problems with Candida albicans. So let's take a look at the others. Tropicalis too, it seems to be that the sensitivity pattern of Candida tropicalis seems to be good, no, from all the polyenes, the azoles, no, and the echinocandids. I guess there's this one that they were having some problem, and it's the Candida glabrata. So they have low sensitivity for fluconazole, and also even for caspofungin, okay? So, and also, of course, the Krusei, and we all know that there are some inherent resistance to fluconazole, and one good thing is that the anidulafungin susceptibility is still high, and also that of voriconazole, And then came the ORIs, and our distinguished speakers have extensively discussed this with us, and their data suggests that this is really the problem when it comes to antifungal resistance, not only in Asia, but I think all over the world. So moving forward, what do we need to do? Well, it seems to be that it's really more of the collaboration and coordination, because each and every one of us has our data. But with that alone, we know that we cannot move forward, and we won't be able to compare our data with that of the other continents. No? So we have to develop synergies, and so that we can also avoid some redundancy in our data. And perhaps because the WHO GLASS is already in place, we can use their protocols and how to conduct, collect, analyze, and present the data. No? And at the same time, at the same time, we have to have a common platform so that we will be able to give or make some real-time information sharing. And for the antifungals, there are also some, and I think more will be discussed later on by the next few speakers, our last speaker for this morning. And so with this, the last slide is my summary. So I was able to present to you the antibacterial resistance trend through the years from the century, the WHO GLASS AMR, and also from selective Asian countries. And I showed you that some Asian countries are performing well, and some need more AMS policies. And the one that I wanted to just emphasize is that there were very low fungal isolates. And the surveillance system is present only for Candida species. And we really don't know the reliability of data then. So the consistency in the surveillance and the reporting and the analysis of the fungal isolates, especially in this part of the world, is very important for us to establish. With that, thank you very much.